Welcome, everybody, to the Ramalingaswamy Center and our colloquium series on equity and social determinants of health. For the last talk of 2023, we are thrilled to have Jashodhara Dasgupta with us here today. Jashodhara is an independent researcher based in India with over 30 years of experience as a policy advocate, community activist, and researcher on gender, public health, and rights-based approaches with publications in many peer-reviewed journals. Jashodhara has set up 4 feminist organizations in India and nurtured national and international civil society networks on sexual and reproductive rights. She has supported grassroots women's leadership through Sahyog, a gender and rights organization where she continues to be on the board. Jashodhara has also served on numerous academic and policy committees, including the first and second Lancet University of Oslo Commission on Political Determinants of Health, Global Governance for Health. She's obviously a towering figure in the field of women in health, and we are thrilled to have her here today. So please, Jashodhara, please go ahead. I'll just make a request to all of our attendees to please put in questions as and when they occur to you in the Q&A box, and we'll pick them up for discussion at the end of our conversation. Thank you.
Thank you so much for that very generous introduction, Abha. And as I start, I think I'd like to share my screen, if that's okay. Yeah. So is it visible?
Yes, it is. It is.
Okay, right. So thank you so much. And I'm really grateful to the Ramalingaswamy Center on Equity and Social Determinants of Health at the PHFI for this opportunity to have a conversation on human resources for health. And I'm really hoping it's going to be a conversation. So everybody, please keep those questions and comments coming. So just to give a bit of background, although I've been working for many decades in public health, my initial work was very much among low-income rural women and their experiences of the health system, in which there were a lot of instances of, negligence, abuse, and sometimes even fatal neglect at the hands of health workers. And because I felt that, the health-seeking behavior of marginalized communities is, critically shaped by these adverse experiences. And it's important to see why providers display these, biased kind of behavior, which is also culturally incompetent and which really emphasizes the power asymmetry between the providers and the users of health services. So I was initially, frankly, in quite an adversarial position, vis-a-vis health providers and health workers. And then it took me several years of trying to understand health systems, in which I was trying to figure out what are the structural factors that underpin this power asymmetry. And it's only over the last 10 years or less, perhaps, that I've been trying to understand the challenges that create the conditions that lead to this kind of mistreatment at the hands of the providers and these adverse experiences for the poorest and most vulnerable. So I just want to quickly kind of draw your attention to the title of what I'm going to say today, which is, are we looking at health workers as experts, as carers, or as servers? And I'm trying to bring a kind of intersectional approach to understanding the power dynamics within human resources for health. And I think the big eye-opener for us in recent years has been the pandemic period. And I know it's not really over yet. But what have we learned? And I'd really like to have this conversation towards, building stronger and more resilient public health systems. Just to, let me just go to the next slide. Yeah. So what I will be looking at today is really a few related questions. The first is really to think about what is the framing of our gaze on various kinds of health workers and which classes of health workers are actually invisible to us. And then how does intersectionality shape their status in the workplace? The other thing is when we look at it in the context of a pandemic, how do gender and other kinds of power dynamics work within the ranks of the health workers and those that they care for and how does that get negotiated in a crisis situation? And then finally, I'd like to conclude with a few thoughts on perhaps how we could think differently about human resources for health, as I said, towards building a more resilient public health system. So, just to address the first question, which health workers are the most visible to us? And when I say us, I'm talking about people like you and me, most of whom are part of an elite and upper middle class population that can understand English and log into Zoom webinars. So, for us, when we think about health workers or when we think about a frontline worker, I think what we first think about are the superstars, and those are the people most visible, which includes doctors, which might be specialists, super specialists that we encounter in the tertiary care centers and the specialized hospitals that we attend. We also see nurses as health workers, and sometimes those of us who are unfortunate have to go and see dentists. Much less when we immediately think of health workers, much less do we think of others like therapists, for instance, physiotherapists or other therapists, technicians like OT technicians, X-ray technicians, and so on and so forth. Then the pharmacists, then administrators, and other staff who are in these clinical centers where we tend to physically see our healthcare being provided. But there is a whole section that is invisible, and it's a bit like an iceberg. So we see a few people at the top, but the ones that we don't see are also people who are health workers, although we don't think of them that way. So these would include people like the sanitation workers, the sewage workers, the mortuary workers, and then, of course, people like the guards and the people in the kitchens, people driving ambulances. Then there are all these, invisible auxiliary workers, including dyes. Yes, there are dyes in hospitals. And these are only in clinical settings. The ones who are even more invisible to people like us are those who are working in the community or who are working out of homes. So, for instance, there are home-based nurses. We all know that. Those of us who have, senior parents and need senior care. Then there are community workers who do things like HIV prevention and outreach, who do public health outreach, and those who work in rural settings. These are not the people we think about when we immediately are asked to name health workers or frontline workers. So when we think about these workers, what is it that we feel that we actually have to understand about them? Why are they invisible? And here I'm talking about the people I just mentioned, which is the sanitation workers, the mortuary workers, the contractual staff, the ashas, the ushas, the traditional birth attendants, and then all these sex workers who could be male sex workers, female sex workers, transgender sex workers, men who have sex with men, intravenous drug users, and others who are also community-based workers who are trying to carry out HIV prevention programs. And basically, they are invisible because of some factors. And this is where actually intersectionality comes in. When you look at this list of categories, what you immediately realize is that most of them are from the absolutely lower classes of our society. So they're economically disempowered. Many of them are from particular castes. So, for example, TBAs or sanitation and mortuary workers are from particular castes of Hindu society. And definitely you can make out that a lot of them are from a gender disadvantaged position. So they might either be women, they might be trans women, they could be women sex workers, or they could be feminized men. And all of these markers also make them disadvantaged in terms of access to education, access to training, access to mobility, and career progression, and so on. It's also interesting that all of these categories are working in conditions that are precarious. so they could lose their job at any moment, that are informal, so they have no social protection or labor rights. Most of their work is highly exploitative in terms of the wages that they get, and they work under unsafe conditions. And the idea is that because these are people who work with their hands, people who work with, for example, bodily waste or bodily fluids or care work or serving work, they are actually unskilled. So they don't have any expertise, in our opinion. And therefore, they are undeserving of any kind of protection. And this, it includes social protection, it includes protection for occupational hazards, it also includes health coverage, and then it includes protection against gender based violence. And of course, I'm sure it's no surprise that if you look at the lowest rungs of the health system, you will find the 80% of women are clustered there. So let me just give you like a short capsule history of the last 50 years of one cadre that I just mentioned. And these are the community-based health workers. Okay. So it's going to be 1924 in a few days. And this cadre actually took off in India exactly 50 years ago in 1974. And this was in Jamkhed, where many of you may have heard about doctors Mabel and Raj Arole. And they actually started working with their first health worker. She was a Dalit woman, and her community had nominated her because they thought her work would involve health care, which includes the kind of lower caste work that is normally presumed to be done as part of dealing with the things I talked about. So this Dalit woman, she was quote unquote persuaded to have a tubectomy so that now she is free of childbearing. And then she was trained to become the first health worker. And of course, this was a brilliant success. She did amazing work. And then gradually in Jamkhed, there was this path-breaking demonstration of how non-literate village women could actually become health animators within their community. And within a few years, actually in 1977, the government also launched a community health worker scheme. And this was very, very much similar to what the Aroles had actually done. And in this, there were, certain jobs, and the women were just supposed to be working just 2 or 3 hours in a day. And then they were women from their own community. So they were given 50 rupees per month because they were working within their community. They didn't have to go anywhere. Okay, let's fast forward to 2005. And this, I'm sure most of my listeners are aware of, that the National Rural Health Mission, now the National Health Mission, started their ASHA program. And there was this very ambitious name given, accredited social health activist. So you're an activist, but you're accredited. So you're recognized. And these, once again, were women who just had, a bare not even high school education, all of them. And they were really meant to bridge the gap, to close the distance between the formal health system and the people, especially those from the marginalized communities. Here again, we see the same thinking continues. They are working part-time and they have task-based incentives. So there's specific things that they're supposed to do, not more than 6 things, and there were payments to be given if they completed these according to schedule. Now, what we see is that this list of 6 things grows over the next 14 years. And gradually, by 2019, what happens is the ASHA is now the conduit for public health functions that require any kind of outreach in the communities. So tuberculosis, you name it, menstrual health and hygiene, you name it, malnutrition, you name it, anything that needs to be done in the community, there will be an ASHA worker who is walking around with a register trying to get this done at the village level. And the number of tasks have now increased from 6 to 43. The interesting thing is, even with 43 tasks, and even after working for 14 years, the piece rate of the payment has remained the same. So she still gets 600 rupees for taking a woman in labor to hospital. Over 14 years, nothing has changed. But we have the Seventh Pay Commission, as many of us here know, and the legal minimum wages is now becoming close to 20,000 rupees. But what the ASHA worker earns is far, far less than legal minimum wages. And she still gets only incentives for tasks. There is no proper salary that is formally given to her. Fast forward a couple of years to the COVID pandemic, height of the COVID pandemic. At this point, in addition to the 43 tasks that she was doing, the ASHA worker is meant to take on surveillance, tracking, data collection, do care work of those who are in the quarantine, do public awareness across the village on COVID, do referral for those who need testing and treatment, and then from January 2021, to start vaccination drives, to mobilize people, to educate them after the misinformation spreading about the vaccines, to accompany them to vaccination camps and so on. So basically, from COVID and thereafter, she's working a 12-hour day. So what do we see now at the end of 2023? We find now there are over 1 million women who are still, quote unquote, volunteers. And the government has stoutly maintained they are volunteers and nothing else. So after years of dedicated work, they are still struggling to be recognized. They're still struggling for decent working conditions. And if they protest, then they face police arrests and repression. So this is where 50 years of the idea of community-based health workers, an idea that was much lauded during Alma-Ata in 1978 as being the formula for reaching health to the marginalized and the poor, this is where we've reached. We may have reached health to the marginalized and the poor, but at what cost? And whose labor have we instrumentalized? So when we look at the public health system in India, what we have to recognize is that it is not only under-resourced, but it is actively being undercut by moving investments into the private sector. So what we now see is that most of our doctors, about 70 to 80% of the qualifying doctors, and I think more than half the nurses we train every year, are all moving directly into the private sector. So we have an inadequate number of health personnel with training. And of qualified health personnel, we find there are 4 times as many qualified health personnel in urban locations as compared to rural areas. And yet we know that 2/3 of India's population lives in rural areas. So who's looking after people in these rural areas? Who is looking after people in these various corners of the country that we don't know about? And I think what we are finding here is also that there is a number of roles that the ASHA is meant to provide. So first, she's performing the role of a health educator, doing preventive and promotive work, but she's also doing the work of a community mobilizer. So whenever there is a Sarkari program, she has to be the one who kind of brings people together for it. She also has to be collecting primary data for the public health system. So everything has to go through her. She has to learn how to manage digital data collection. And then she occasionally has to also provide curative services. Now, in all of this, where is the social health activism that is in her name? That's the question. What she has become is a kind of shock absorber for this health system, which is really in a very crumbly state. And what makes it easy to keep them stuck at the bottom of the health hierarchy is that they have come from poor families. Many of them are Dalits and they are from minority groups and they have low educational qualifications. And of course, their payment is not only low, but it's also precarious because it depends upon the work that they do. There's nothing which is guaranteed. The fact remains that they do not have decent working conditions. They don't have fair wages, but they have no form of social security, and the state does not actually ensure their freedom from violence and harassment. We also find that the kind of gender barriers women face everywhere, like the gender wage gap, and the fact that women don't have a career path, there's no growth opportunity. That is also true for ASHA workers. What is most interesting here is that for these so-called volunteers, the state is the employer. But the state has erased its own responsibilities by giving them the volunteer title, by retaining them in informal working arrangements for over a decade, and is not honoring its own legal obligations to give fair wages, social protection, and so forth. And one of the most interesting things was that although ASHAs face violence and harassment in the workplace, the state has refused to include them in the law on sexual harassment in the workplace. So they are not actually provided any legal protection by the state, which is their own employer. So, what kind of power dynamics did we see during the pandemic times? Okay. Now, I think the pandemic was really for us, it was just a kind of way of seeing how, institutional discrimination and hierarchy operate. It was a very stark example of that. So, first, we see that ASHA workers are at the very forefront of the pandemic response, they are everywhere. But we find that, ironically, they are even more powerless, even more marginalized, more overworked, and vulnerable. And this was because, firstly, the Ministry of Health and Family Welfare, in their infinite wisdom, said that the job of ASHAs, and I'm sorry to say, it's also the same that they said for all the other invisible frontline workers, is because they are in a low risk situation. They do not require protection, even though they are in direct contact with potentially infected people. The Ministry of Health and Family Welfare did not insist that they should be given personal protective equipment. They were not allowed to access proper testing at regular intervals. They were not even given training in the early months of the COVID. It was just on telephones and WhatsApp messages. There was very little supervisory support and guidance. They were expected to perform all their 43 tasks and the new COVID tasks. There were delayed payments. Their actual incentives were delayed, and they were promised these additional incentives for COVID, which were not given to them on time, which were given to them sometimes as much as 6 months later. And they had to go for 12 hours of work. But remember, they're also women, and they're low income women. So they have school going children, they have older people at home, they're too poor to have someone to come and cook for them. There was no food security, there was no support for childcare, and there was no transport provided to them. And they had to work round the clock. The interesting thing is, while exposing them to the infection with this kind of callousness, there was no sick leave for ASHA workers. Their medical expenses were not covered. Neither were their family members, because this is an occupational hazard. If you get an infection, you bring it home and your family members get infected as well, including older family members. But there was no coverage for their medical expenses. And there was insurance, which has been much touted as how much the government cares for the ASHA workers. This insurance was only in the case of their death. And so ASHA workers have made very cynical remarks about how it's their death that is actually the only thing that gives them value. And that is when the government actually gives them a large amount of money. So the very ironical thing was that these ASHAs were honored in May 2022 as these global health leaders. And they were actually given this WHO award. All the 1 million of them, they got this award. And the kind of things that they say, that all big schemes, whether it's polio or COVID, basically rely on scheme workers like us. We are the ones who do the work finally, and the public health system rests on our shoulders. But when it comes to acknowledgement, we are not even recognized as employees deserving a minimum wage. In a SAM, one of the ASHA workers said that we are called Corona Walas. We are kept at a distance by our neighbors. because we're in touch with community members without wearing PPE. In Andhra Pradesh, another ASHA worker says, we are like worms in the eyes of our higher officials because we come from poor families and we've only studied until the 10th grade. So this statement, I think, really brings out what we mean by intersectionality, is that here are women who are working their backs off, who have not been able to invest in education and training like doctors and nurses, but they are providing crucial services at the place that's needed most, putting themselves at risk in the line of duty. But they are like worms in the eyes of the higher officials. So, this is where we see how this almost caste based, class based disregard of those who are from disadvantaged groups leads to their sense of inferiority and low self worth, making them feel powerless and actually leading to mental health problems. And it's quite encouraging, I think, that one of the government health worker officials actually acknowledged this in a published paper. She said the assumption that poor women can set aside time for volunteer work is deeply problematic. People who are privileged, like many of us in this webinar, we barely set aside time for volunteer work. And here we're expecting someone who is really at the bottom of the social pyramid to do it. And all these structural barriers that they face also prevent them from progressing in the health workforce. So let's have a few minutes to just talk about voice, leadership, power, and accountability. So here, I think one of the things we must acknowledge right away is that the ASHA program has enormous potential. It's undeniable that these were, married, rural bahus who have been drawn out of the so-called chardivari of their household into the public domain. And this the state has done. It's a government program that has done this, and that government legitimacy has actually enabled them to, overcome the critique of their communities, the opposition of their families and their in-laws, and to come out into the public domain. So this actually has brought 1 million women into positions of community leadership. This is undeniable. And this has huge potential to be a role model for other women, for girls, and especially those from marginalized groups. So this is an option that has been opened for women from minority communities. If you look at this photograph on the left, a lot of the women who are marching here are actually Muslim women. And here they are out on the streets fighting for their rights, right? The only thing that we have to remember is that while they were called social health activists, this is actually a misnomer because activism is certainly not allowed. They are at the lowest rung of the health system. They are already women, Dalit, poor, not very educated. There are so many disadvantages that anyway keep them at the bottom of the social hierarchy. And even labor unions, which are mostly led by men, have not actually taken up the issues of the ASHA workers with the kind of energy that was needed. So activism is really difficult for these ASHA workers. How do they make their voices heard? How do they actually make their issues, how do they claim their issues, their rights, their entitlements? We found it most interesting that while the ASHAs were at the forefront of the pandemic response, they were not consulted at any point in time by the government. There was not even the semblance of including them in decision making to bring them into the table where all these decisions are being made. And pandemic response policies, as I think most of us remember, the kind of rules that were put into effect with practically no notice at all, are the kind of policies that are shaped by the experiences of the elites, the most privileged people who have ample personal resources. So it's okay for them to, make rules like wash your hands 20 times a day, because obviously everybody has infinite amounts of piped water supply and so on. And all the norms about social distancing, they really ricochet back on these ASHA workers, because people began to distance them, their families began to distance them. So they were playing this role which was essential. There was no way the pandemic response could have happened at the scale that it did without these ASHA workers. But because they are women, because they're at the bottom of the hierarchy, because they are not formally educated, they were not consulted. How do we see the word ASHA, the A of the ASHA, which is the accredited? Who is the ASHA actually accountable to? And that's a very tricky question, because the minute you say accredited, it means that the ASHA actually is answerable to the people who have given the accreditation, and that is the accreditation by the state. Because she is the lowest cog in the health system, she has to be accountable to the A&M. The MO of the PHC can also pull her up and ask for data and so on. The CMO can misbehave with her, can deny them their rights, can deny them career paths to move ahead and do something more meaningful, after 10 years of being an ASHA. All of this shows that she's completely under the control, under the power of the health system. But she is not a social health activist, and her accountability is not facing the community. The question that arises for us is, what would happen if she actually became answerable to the community? And what would happen if she was made a formal worker with a proper salary, with social benefits, and made answerable to the community? The argument that is always given is that the minute you take the control of the health system off, if the A&M and the CMO and the MOIC are not actually demanding accountability, the ASHA workers will stop working, and the community will not be able to actually take their reporting in that sense. And the other reason why actually she's not given a formal salary and worker benefits is because, and these are extremely privileged officials who are growing fat on the compensation of the Seventh Pay Commission, officials say that if we give her her workers' rights, which is her social protection, if we give her the fair wages that she should be getting, then she will actually become less accountable and she will take us for granted. The minute she becomes a formal, quote unquote, government employee, she will stop being productive. And then, of course, I would say, point the finger at yourself. So what we have is, I would say, an almost a paradoxical situation where we have this powerful human resource in which the state is unwilling to invest. We have the lowest investment, the lowest kind of payments that are stagnant for 14 years being given to these women. And ironically, their labor rights are violated by the state itself. And of course, this is also poor public health practice, because if they were really working with full support and resources, they could have turned the community into a very resilient, public health responsive, active community. So I would like to wrap up by giving a kind of feminist analysis of the ASHA program and then talk about a few ways forward. So I'm just quoting a couple of feminist writers. So one is Krista Wichterich, and she says, the deepening privatization, corporatization, and neoliberalization of the care economy has led to a reliance on the lowest end of the health hierarchy, the majority of whom are women. And Krista also talks about the concept of care extractivism. And she says this is the intensified commodification and exploitation of the resource labor in social reproduction for the purpose of managing a crisis situation without burdening the state or the health industry with any additional costs or responsibilities. And here we find how gender and social disadvantage really kind of effortlessly segue into this framing of our gaze of the Asha. So, women's economic activity, she is a worker and she should have workers' rights. This effortlessly turns into community volunteerism, and it's kind of seen as seva. Just like women do unpaid care work within the household, this is seen as a community extension of the same kind of seva. And we find health policies echo this. So they naturalize the work of community health workers as women's work. And this is very patriarchal. It's very consistent with those kind of gender norms that actually obscure and diminish their status as professionals, as healthcare experts who are working in a critical area. And King also during the COVID mentioned this inequitable division of what is paid and what is unpaid in the world of work. It really aligns with the well entrenched gender norms. And these define women as the caregiver, and they are nurturing, they are self sacrificing. So they should not only care for the household, but for the community. So here I would like to wrap up, and I feel that we can think differently using an intersectional lens. And I'm mentioning three domains where we need to think differently. One, of course, is our gaze, is at how we look at frontline workers. The second is in the design of our programs for public health. And the third is in our policy making and resources. So, in terms of our gaze, I feel to think differently, we have to begin by not seeing frontline workers as carers, as servers, as volunteers, but as colleagues in the health system who are to be respected because they are doing substantial work. And in their own domain, they are actually experts. So, what they manage to do in the community, there are very few other health cadres who would actually, accomplish that. And their roles are crucial. So, they must be respected as equals. The second domain is that of design. The top-down design of all schemes and programs, which is always based on the understanding of upper middle class elites with very different kinds of education, makes it difficult for any kind of local, adaptability, for any kind of local flexibility, and for health managers who are at the front of dealing with these cadres to actually modify the way programs have to be rolled out. So I think what we have to build into the design, if we want to take it through an intersectional lens, is to remember the multiple and intersecting disadvantages of the ASHA workers and the other frontline workers I have already mentioned, to remember their situation and to remember that they are performing an essential function for the very deprived, the very marginalized communities with whom they are trying to bridge the public health system. So we have to give the flexibility and we have to give the time for health managers so that they can assess the situation, so that they can consult those at the front lines, so that they can monitor what is happening, and most important, so that they can, in a decentralized manner, modify the approaches that are being adopted so that we can overcome all the barriers that are being created by these unfair systems that have been designed in a top-down manner. Finally, the most important, where's the money? I think we have to think differently about resources. For too long, these dedicated women have been subsidizing the public health and safety of everyone in this country. And this really needs to stop. We have to stop seeing them as a cheap way to attain all our public health goals. We must increase our investments in order to create resilient and community-oriented public health systems. And within this, we must ensure that for all these frontline workers, there must be formal, legally mandated working conditions that should have the fair wages in keeping with the Seventh Pay Commission. They must be given all forms of social protection, including leaves, including compensation, and all the other benefits that must be given to them. They should be given support services if we expect them to leave home and work for several hours. And that includes childcare, food support, health coverage, and so on. And most of all, because many of these are women, we must ensure their safety within the workplace. So I'd like to stop with that. I'd like to close in solidarity with all the frontline workers who are struggling for their rights. Thank you very much.